My name is Dr. Paul Yong. I'm a gynecologist with a fellowship in endometriosis, pelvic pain, and advanced laparoscopy. I'm a gynecologist at the BC Women's Center for Pelvic Pain and Endometriosis in Vancouver, Canada, where I am also research director. I am an associate professor at the University of British Columbia, and I hold a Canada Research Chair in endometriosis and pelvic pain. Yes, so medical treatment of endometriosis primarily consists of therapies that suppress hormonal levels, particularly estrogen or estradiol. So there's a range of medications that can do this. Some of them involve actually giving a form of progesterone or progestin with or without estrogen in order to reduce the body's own production of estrogen, while other ones don't involve that. They are called GnRH agonists or GnRH antagonists, but they all result in a reduction in the body's own production of estrogen and also probably the endometriosis lesions, their own local production of estrogen as well. Issues there include side effects. So at our center, 25, 30, 35% patients or so will report having to stop certain hormonal therapies because of side effects. And in I'd say our clinical experience, probably mood is the most common. For surgery, is laparoscopic excision of endometriosis lesions. In a subset of patients, if they completed childbearing, there could be a role in some cases performing hysterectomy at the same time if that's the patient's choice. However, the more common and first treatment would be excision of endometriosis. So some of the issues we face when doing this surgery. So first of all, if it's more significant anatomical endometriosis, so like the deep subtype, higher stage, then there is the issue of ensuring that the gynecologist has had the surgical training, which in Canada is primarily now through clinical fellowships after residency. Another one is trying to predict which patients with endometriosis will actually respond to surgery. So we published a study from our center of hundreds of patients after excision of endometriosis, and on average, pain improves, quality of life improves, which is what we hope to see and expected, which was good. But there's definitely a minority that did not have the improvement that we saw in other patients. So we've been doing a lot of work over the last, really over the last 10 years to identify factors before surgery, which predicts whether the patient will respond to endometriosis surgery or not. A third approach is a holistic or multidisciplinary approach to care. And I think this is important for a couple of reasons. So first of all, whenever one's dealing with pain that's become persistent or chronic, it's been recognized that a holistic approach to pain is important as it's a biological, psychological, and social phenomenon. Also, why it's important is endometriosis can coexist with other causes of pain, whether related to the bowel, the bladder, the musculoskeletal system. So if one really wants to get the maximum impact on pain, then one needs to treat the endometriosis, yes, whether through surgery or medical therapy, but also the other causes of pain as well. So that would depend on whether we think the pain is coming from the bowel, bladder, or the musculoskeletal system. One issue we face is that it seems that it's ideal that these holistic treatments are offered together with surgical and hormonal therapy. However, that type of interdisciplinary environment where multiple care providers are working together is still a need to ensure that these types of centers throughout the country. So I think there are several strategies that general gynecologists can employ in their practice. So the first is, as gynecologists are already doing, is to continue to listen to patients and to validate when they present with symptoms of pelvic pain or endometriosis. Second thing, for communication, I find visual communication to be useful. So diagrams, images to accompany the verbal communication when physicians are giving recommendations. Also, something like a patient passport that summarizes the visit in terms of what were the findings and what were the recommended treatments. The third aspect is for general gynecologists, I would just say, is for treatment, is again listening and personalizing treatment. Whether it's surgical, medical therapy, or interdisciplinary, I will tend to sort of go through this diagram of what were the different contributors to pain. So it could be endometriosis, it could be other concurrent pain conditions as well, and then talk about the rationale, how each of these treatments addresses each of the causes of pain, and also what are the limitations of each. And then I try to present that to patients and then let them give their feedback, how they feel about each of those options. And that might depend on their own values, their previous experiences. And I try to adjust my recommendations based on each person's current situation rather than saying it's sort of a one size fit all. Another principle I think useful for general gynecologists is a life cycle approach to endometriosis. So, a patient at 18 might be interested in a certain type of diagnosis and endometriosis. For example, just from the history and examination might be sufficient for them. And a particular type of therapy, maybe medical therapy. Someone in their 30s, at that same person, things change. Now the type of diagnosis might have to be modified. The type of treatment might be modified. Similar as a patient approaches menopause. So just to keep in mind that how you diagnose endometriosis, how you treat it can evolve over time, even in the same patient. And so it's key to continually keep in mind that personalized life cycle perspective. On the horizon for pain management for endometriosis, I think, is a non-hormonal medication for endometriosis. Currently, the medical therapy is mostly involves hormonal suppression. There are also NSAID medications, which reduce inflammation, but they all have a smaller effect on pain. So a number of research groups and our team here in BC are also very interested in working with industry for drug development for a non-hormonal drug that can treat pain in a different way. So it doesn't mean that we won't use medical therapy affecting hormones. It might be both, for example, but at least having the option of a non-hormonal drug. And it's particularly important because endometriosis is also associated with infertility. So really the ideal would be a non-hormonal medication that could still allow patients to try to conceive if that's what they would like to do, and that treats the pain in a different way and really treats the biology of the disease as well.